You're just about to leave work for the day, and you see your last patient. Now, it's a fairly common encounter, and nothing is really alarming at all at first. You are seeing a 54-year-old male for his yearly physical exam. You've been appropriately managing his type 2 diabetes for about 10 years, and he shows up for this drill every single year. He's fairly well controlled on metformin, but during the foot exam, you notice something a little bit off. He seems to be losing feeling on the plantar surfaces of his feet. So you check to see if there are any wounds. Now, unfortunately for this patient, there's a rough callus forming, which may be a little worrisome. Quickly, you pick up the phone and call Dr. Bruse before his clinic closes and get him on the schedule for tomorrow. That simple act may have prevented an amputation. Tonight, we have the great opportunity to learn from Dr. Jason Bruse, a foot surgeon extraordinaire, about diabetic foot issues.
I grew up in Salt Lake, went to West Jordan High School. Then I graduated high school and went to BYU for undergrad. I went on a mission to Japan, finished at BYU, and then I got accepted into podiatry school and went to podiatry school in San Francisco. It's unioned with UCSF, so I lived right in the city and did 4 years there. I got my surgical residency training back here at University of Utah. And so I spent 4 years there, surgical training, and that split time between the U, VA hospital, and IHC hospitals. In my second to last year, I believe, of training, one of my rotations was up at McKay in their diabetes clinic. They had a rather large diabetes clinic. Dr. Jack Wallen, who everyone's probably heard that name, but he ran the diabetes clinic up there at McKay, and he wanted another podiatrist. He'd already had a podiatrist there. They offered me a job when I was rotating up there. And so when I finished my residency in 2003, summer of 2003, I joined the Intermountain Medical Group up at McKay. I was there for probably 3 years, and we just got so big. I had a partner there at the time. We decided to start the McKay Foot and Ankle Clinic, which is a standalone clinic, not really part of the diabetes clinic anymore. And that still stands today. That's a busy clinic up there today at McKay. And then I was hired by Ogden Clinic about 5 years ago, and I moved back down a little closer to where I live, down in Davis County. So that's me.
I didn't realize you really started that foot and ankle clinic. That's pretty impressive. How about some hobbies, talents, interests? What do you do in your free time?
I love all things outdoors. I like to go on walks every day, take the dogs on a walk. I like to go up on the mountain. Love to fly fish in the summer. We have a boat and go boating. We like to snowboard in the winter. We talked about this when we were scheduling this, but we're just going up to Targhee next week with the kids to go skiing. They love that place up there. And so we just like to do a lot of outdoor stuff.
I just got back from EA last night, and my brother moved there. So I wonder why you have chosen Maui as your favorite island in Hawaii.
We go there a lot. My wife has a friend who lives there. He's a dentist on Maui. Okay. And they have a great house with a guest room and a guest bathroom, and it's always open. And so we always have a place to stay over there. We just love Maui, so we go there a lot. We're going again next month as well. We just went in January with all the kids. I don't know. I should probably move to Maui.
after being there a week during this pandemic, I'm ready to join you. So let me know when you head
it's
there.
Been great. It's funny. It's safer over there than it is here for sure, right?
Oh, definitely. So any conflicts of interest in your presentation today at all? Any conflicts you have to disclose?
No, shouldn't be. No.
Well, I'm sorry you don't have any, because I hear it's nice to have those kind of...
I know. I wish I did have something with conflict.
Awesome. Well, Jason, let me go through and cover some of the questions for this. And so I think one of the first things we want to talk about is what kind of things do you see most often in your practice, Dr. Bruse? What are things that what comes to your door most often?
It's changed a little bit. When I was at McKay, because we were in the hospital itself, we got a lot of messy things sent directly to us. Gunshot wounds and something that happened in the ER. I had a kid put his foot in a rock crusher, and his foot was in about 25 pieces, and it was literally just dripping blood out of his boot. They wouldn't take his boot off. They just called me, and I mean, so I saw lots of trauma and stuff like that at McKay, and certainly a lot of diabetes complications. We were kind of the only ones. And for a while my partner left up there. So I was the only guy there before any of the foot and ankle orthopods got to McKay. I was really the only guy at McKay for a couple of years. So those are busy years, seeing basically every foot that came into McKay. And then when I left McKay and left the hospital, my practice moved to more of a private practice setting. So now I see a ton of injuries, a ton of sports medicine. It's mostly a surgical practice. So I do a lot of elective surgeries, a lot of bunions, lots of hammer toes, ankle stuff. I see a lot of athletes. I see a lot of athletes from our surrounding high schools. I see a lot of runners. I see a lot of the athletes up at Weber. I'm the official surgeon of the Oregon State women's gymnastics team, apparently.
Oh, I would not have guessed that.
I wouldn't have either, and nobody else would. I just had a couple of the patients up there. There were I believe two girls that were from here, at least one girl from Utah that got a full ride scholarship up there. And I had worked on her in high school, and she needed a surgery while she was up at Oregon State. And so she told her trainer she wanted to come back, and she flew back down here. I did her surgery. Then it went well. And so the trainer called me and said, we're going to send another girl down to you. And after that, they said, guess what? We're sending them all down to you. But they haven't sent anybody for a while, but it's funny.
Go Beavers.
Go Beavers, exactly. So no, I see lots of athletes. My practice is a little bit different than it was at McKay. I definitely still see some diabetes, but because I'm not actually in the hospital where a lot of those acute things need to be seen, within hours sometimes, I don't see quite as much of that now.
Well, you may see more foot gunshot wounds with the dropping of concealed carry permits. And so
I know. I just saw that this week.
We'll see how it goes for you. So.
No kidding.
Has COVID-19 impacted your practice at all in the cases you've been seeing? Or
yeah, we were actually just talking about this today. It's interesting right now. I think that a lot of people that see a lot of Medicare, I don't see a ton of Medicare, but I think there's still some definite fear out there amongst the community, amongst patients to go outside, I think. So volumes are down in the clinic for sure. They were down, obviously, initially. We got shut down in May. I could only do emergency surgeries in May when the hospitals kind of shut that down. And so I did have, I don't know, maybe 10 cases in May that had to be done, infections or a fracture or something. But most of my elective stuff really shut down for the month of May. But then it really picked up fairly well in the summer and in the fall. And then it seemed to kind of slow down again. So it's kind of still slow right now. And I don't know what that is, but we're seeing it kind of across the board in our group, and everybody's Medicare visits are down and overall visit numbers are down. And aside from that, there's nothing really that I see COVID specific. Although people ask me if I've seen COVID toes, I have. I've seen a few. Yeah, I have.
That's interesting.
I thought you might have more athletic injuries. People are outside so much more and do so much more hiking and backpacking if it changed the amount of foot.
Yeah, I would like to. I think it did in the summer. I think they were doing a lot of that stuff, but a lot of organized sports weren't really happening as much. So yeah, I had a busy summer and a busy fall. It's just kind of slowed down recently though, and we're not really sure what that means. But
yeah.
Let's talk about shoes. I'm a runner, and so I like my shoes, but I have to be very specific about which shoes I get because they have to fit me right. What do you see with like running shoes or barefoot running or high heels? Like we have patients that come to us a lot with these questions, and it's like, well, we're not the experts, but you are.
A lot of times my answer is I'm not really sure. And so that's an interesting and very large topic. When I first started practice, I did a ton of research in school and in residency, and worked with a lot of athletes. And I flew around the country lecturing to patients, to running groups about how to pick a running shoe. And I had this big display, and I would pass out half-built running shoes halfway through the construction. And I had nice running shoes that I had sawed in half. And I would pass them around to show patients, the differences between the EVA molds and the different materials. And I would have this big lecture about what kind of a foot type you have, how to pick your running shoe for yourself. And that was the dogma at the time. I mean, this is probably, 2000s up to about 2010. And then it's really interesting. There were some landmark studies that came out. I believe the first one's about 2008, right around the time that book Born to Run came out, right? So there were some landmark studies that came out. A couple of the studies were done on cadets in the military, where they would take a large number of athletes, a large number of cadets, like 5,000 patients, randomize them. And then they would take half of them and walk them through in front of a doctor who would look at their foot type and say, okay, here's the shoe that you need to be in. And it basically diagnose them with a foot type and prescribe them a shoe and let them go run for 6 weeks and do their normal basic training stuff that they had to do. And then the other 2,500, they just said, do whatever you want, pick whatever shoes you want. And they repeated that study multiple times. And in essentially every case, the group that had the doctor looking at them, picking a shoe, had more injuries. It kind of threw that whole industry on its head, honestly. I mean, there was a lot of things that I learned in school, a lot of books written about how to pick a running shoe. And that kind of all went out the window. And it kind of looked like a lot of that was kind of hogwash, which is really interesting. I mean, I lectured in front of hundreds of people through those years. And now we're learning that a lot of that stuff that we were teaching probably wasn't right. So people ask me a lot about barefoot running, and we should talk about that a little bit, kind of in that whole topic of running shoes. But what I tell people now is, for sure, shoes matter. A lot of the more modern and recent running shoes have a ton of room in the toes. And the popular brands that you'll see, they are expensive, but they have a lot of room in the toes, and they have maybe not quite as much padding in them, especially in the heel. One of the things that we believe happened early on with running shoes, when Nike first came out with running shoes, they used like a waffle iron in the late 70s and made these running shoes literally with a waffle iron, pressing rubber molds, right? And it wasn't called Nike at the time. It was the guys who were making them became Nike, but they made shoes with a ton of padding in the heel. And that allows you to run with a really hard heel strike because it doesn't hurt, because you've got so much padding, which is a little bit unnatural. And the belief is that 20 or 30 years of the world running with really well padded running shoes that were a little bit built unnatural for our foot type maybe led to a lot of injuries. And so that Born to Run book that came out talking about barefoot running and moved to more of a minimalist shoe approach really kind of changed the running shoe industry quite a bit. So now when people ask me, what do I think about Born to Run? What do I think about running shoes? I always tell them, look, you ought to really know what kind of a general foot type you have. Do you have a high arch foot? Do you have a low arch foot? But you can kind of stop there. You don't need to get super detailed about it. You kind of divide yourself into kind of a neutral foot, a high or low. I mean, there's basically 3 generalized foot types. And then you go to a good running shoe store and you find your wall of shoes, and in your category of foot, there should be at least 10, but maybe 20 or even more shoes that could potentially fit your foot type, and you try them all on and you go for it. And if it's a good store, if they'll let you run on their treadmill and try it out for a while without buying the shoes, or they'll have like a 7-day return policy where if you didn't like it, you can bring it back. And because there's no doubt running shoes and the wrong running shoes can cause injury. There's no doubt about that. And so that's what I tell people now is it's trial and error. It's finding the shoes that feel good. And if you get a shoe that feels good and you're in a good place, stay there. Keep buying that model. Don't change up. There's no reason to change up. It's different if you're getting like racing flats for a race or something, but that's, for a high level runner, that's a different story. If you're a recreational runner and, run your 10 or 20 miles a week and stay with what works and try not to get injured. I mean, the numbers are fairly drastic and dramatic. Runners, about 85% of runners get hurt every year in some part, in some way. And so if you can remain uninjured because you've got the right shoes, then stay in it. The other thing that I would say about barefoot running, I should talk about that. That book's really fascinating. It does bring up some very good points that I mentioned briefly a second ago, but running barefoot, first of all, it's not for everyone for sure. Some people just don't have the right foot type to do it. But high-level runners oftentimes will train barefoot because it does change your mechanics a little bit. You can't just land really hard on your heel. It shortens your stride a little bit. You use a little bit different muscles and you land a little bit more on the front of your foot when you don't have anything on your foot for padding. You land on the ball of your foot a little bit more. And so you have a little bit different running gait, which is probably a little bit more correct And so barefoot running can be good for people, or minimalist type shoes can be good for people, but not everyone. And I give this speech to a lot of people, and we're learning more and more about it all the time. So that was a really long answer to your really short question.
And that's really funny because after, a good 15, 20 years of just practicing trial and error, trying to find what shoes work for me, I've gone to exactly that. I've found for me personally that the more minimalist running shoes work very well. My speeds increase, my injuries decrease, and it just feels natural.
It's because you're running on a better gait, and you can find that. I mean, it's pretty fascinating to look just on YouTube. You can find people, they'll take a high-speed camera and they'll position it and show a lateral view of someone running on a treadmill at a constant speed, but they'll put a shoe on with a big padded, like the olden days, a shoe from, 1990 or 1995, a really well padded running shoe. And then they'll take off that shoe and have them run barefoot, and their gait changes for sure. You have a shorter stride length. You have a bigger kick in the back. It's probably softer on your knees, your hips, your back. It's probably softer on everything to run that way. And that book, the Born to Run book that talks about those people who can run a marathon every day, and they're running basically in barefoot nothing, and they're, they don't get hurt. And, you take those people and put them in a running shoe and it hurts them. It's quite a fascinating topic for sure. I mean, and not everything is known about it. The one thing I think is insane is that the one kind of star of that book who ran, 20 or 30 miles a day died of a heart attack at like 58 or something, which is maybe a topic for another show, but that doesn't make much sense either, right?
Well, that's why I tell people you shouldn't exercise too much. You have a limited number of heartbeats in your lifetime. You don't want to spend them all too soon by running too much.
Like I agree. But I mean, I don't know if you're joking or not, Jason, but you might be right. I mean, how can this guy who runs 20 miles per day suddenly have a heart attack? I mean, that doesn't make sense, but he did.
Hypertrophic cardiomyopathy, maybe.
Yeah, I think HCM probably. And so
it could have been a lot of things. You're right.
I do joke about it, Jason. I tell people, you don't want to, spend all your heartbeats running, and so it's.
I hear you.
So take your time, hang out on the couch, and so it's.
I hear you.
I guess one of the things for you, Dr. Bruse, is when you work on the shoes and the prevention and the orthotics and everything, but when it comes down to surgeries, what are some of the things you do most often out of your office, operating room, and maybe some new things you're doing, and so you're branching out to?
I do several things in the office. I'm always digging something out of somebody's foot, a needle, piece of glass, a tack, you name it, sewing needles or hypodermic needles. I mean, people step on things, and older people step on things. And if they're diabetic, they don't know they've stepped on something. And so if the ERs, take an x-ray and they see something, they'll send them over to me because I've done so many of those. I have some tricks to getting stuff out. So I do a lot of that in my office, but I also do a lot of ingrown toenails and warts. And so I'm sure I've seen some of your patients, Jason, that I see a lot of kids with ingrown toenails, a lot of warts. Most of the warts that I see are people who've tried to burn stuff off of their feet, or their dermatologist has, or their pediatrician or family practice. And it just sometimes doesn't work. And so I have some stronger stuff for that, but I do some procedures for sure in my office. Most of my surgery is done in the operating room. I'm a specialist in a couple of different bunion surgeries. I think I do the most in the state of a couple of different bunion surgeries. I replaced toe joints. So a lot of people don't know this, but we can take a big toe joint and replace it. The pieces look just like a total knee joint. I do that the most in the state for sure. I lecture for that company and in that surgery and teach people how to do that. And so I'm a specialist in that and some bunion surgeries that I do a lot of. So yeah, it's a great practice.
It's nice having the full range of everything. So that's awesome.
You sound like you're staying really busy. So what's your daily schedule like, and kind of what's your call schedule?
Well, I'm now at the Layton Hospital primarily. I don't really go to McKay anymore. For a while, I was the only doctor at McKay taking podiatry call, and that was fun. Now I'm at Layton Hospital, and I'm the chief of podiatry there. And we have a call schedule there. It's not really intensive. It's not an intense schedule because there's not a lot of acute stuff that will come to that hospital. But I do have call at night, and a lot of people say, wait, you're a podiatrist. What are you doing at nights and weekends? But because of my training in the first part of my career at McKay, where I made a lot of connections with people a lot of ER docs in Ogden, and I had to do a lot of trauma and acute diabetic stuff. And so I still get those calls at nights and weekends. And, those are things. An acute diabetic foot needs to be seen on the weekend. You can't wait. And so my schedule now is I'm in surgery all day on Mondays, in the office on Tuesday, in the office half day Wednesday. The rest of the day Wednesday, I am in the operating room again. And then Thursday in the office all day. And then Friday is kind of hit and miss, whatever I can. If I can get away and go skiing, I will. If I need to do surgery, I will do that.
Hopefully you've had a little bit of snow fever the past week or so, Jason.
We have. We've been snowboarding twice in the last week. It's been great. So.
Are there any kind of, as far as wound treatment options that you find, using more often? Anything kind of more cutting edge in wound treatments?
Well, I mean, I definitely see diabetic wounds. I think every podiatrist does. Diabetic foot is certainly a problem in this country. As you guys know, there's, I think, about 35 million diagnosed diabetics. There's about 80 plus, maybe 85 million people that are pre-diabetics in the country. And so in those pre-diabetic, that category of people, they oftentimes have foot problems. In fact, most of the people in that category, their first complaint related to diabetes is their feet feel kind of numb or tinglier. And they'll get that years before they're ever formally diagnosed with diabetes. And so there are a lot of people out there that face issues like this, and every podiatrist sees diabetic wounds. The main principles of getting a diabetic wound to heal is you've got to get the pressure off of it for sure. You've got to make sure you've got the infection covered. If there is an infection, you got to make sure it's not infected. And then you've got to make sure there's an adequate blood supply to the area. And those are the kind of the three principles. If you have those three topics covered, you can usually get something to heal. And, I have this talk all the time with patients in my office and talk to them about, what we worry about as foot doctors when we see somebody. And just because you have diabetes does not mean that you're going to lose a toe or a foot or get your leg amputated. That does not mean that at all. What it does mean is that you've got to be really careful, because a diabetic could walk along and step on a nail and they may not even know it. And if they don't know it and it gets infected because they're numb in their foot and it gets infected and then they don't really seek help on it for a few days because they didn't even know there was a problem down there, then we're behind, and we're behind the eight ball sometimes, and we've got real problems where a non-diabetic would immediately feel that if they stepped on a nail and they would get attention for it. And so I spend a lot of my time in my office talking to diabetics about that very thing, that nothing has to happen bad in your life regarding your feet. You don't ever have to have a real problem or a wound or anything like that. You never really have to have a surgery. It's not your fate, but you got to play really good defense on your feet, and you've got to really watch and check every day. And then, if there is a wound, then we check their blood flow, we make sure it's not infected, and we get their weight off of it, and we do our best.
In residency, I spent every other day at the VA hospital in Tucson, and I basically had a fridge full of amputated legs, and it was every day, every other day, and that's the kind of that's kind of the true story, is that the vast majority of these cases, they did have like an osteomyelitis picture because they weren't careful enough and they ended up stepping on something. And I would say that was the majority of cases. There were a few in the minority that didn't.
The patients will say they stepped on something. It's funny how many times I've heard that I stepped on a Lego. I don't know what it is about Legos or what people think they stepped on Legos, but I hear that story all the time. But they'll say they stepped on something. Oftentimes it starts just with old-fashioned kind of a wear spot on your skin. And that's probably the most common reason. It starts as a callus. They don't really realize that a really heavy, thick callus is not good. And if you keep walking and the next step after a callus is that skin will open up and then you've got an ulcer, and that's right over a pressure spot. Everything changes though, as you know, being a pathologist, when the infection gets into the bone, that's when it's really serious. We can handle a lot of infections if it's in the soft tissues, if it hasn't got to the bone yet. So that's what I spend a lot of my time in my office talking about. If there's a small infection, I tell my patients all the time, look, I've amputated, unfortunately, thousands of things, and I wish I hadn't. But in almost every case, it started with something pretty small. And so, and the patient didn't know it was there or didn't think it was a big deal. And so I really spent a lot of time educating. And if you've got diabetes, someone needs to look at your feet every day. If you've got a cut on your foot, you get right in. Let me be the one to tell you this isn't a big deal, but don't you decide that it's not a big deal, because as a diabetic, things really snowball quickly. You don't have as good a blood supply. You don't fight infections very well. You get infections easy. You don't heal wounds well. It can spiral really quickly. And so I tell patients all the time, nothing bad ever has to happen. And in almost every amputation case I've had to deal with, it started with something pretty small. It's not something exotic like I got bit by a rattlesnake and there's nothing I could have done about it. It's almost never that. It's usually something pretty small. They either didn't know it was there or they didn't think it was a big deal. And so I spent a lot of time talking about that principle itself.
Oh, thank you. I think that's really good advice all the physicians here can give our patients. Now, I'm wondering, I'm just curious, do you have like a memorable story about someone who came in with a foot issue as their first initial presentation of diabetes?
You didn't have Larry Miller as one of your patients.
No, and that's a really sad story. I was connected partially to that, but I've had a lot of patients like that, and what is sad about diabetics sometimes is they get this kind of despair in their worldview, and they, things keep happening. They get an infection, on their other foot, and then they get a bone infection, and they've got to get a PICC line again and again. And I think they get this kind of despair and they say, enough, I'm not doing this anymore. And that is the sad thing that happens. But I mean, I had a patient years ago who came to me. She was just recently diagnosed as a diabetic, just recently. But that wasn't really an issue. She had this draining cyst in her ankle. So I looked at it and she said, I've had surgery on this, and he cut out the cyst and it came right back. And then I went to another doctor and he did the same thing, and another doctor. So she'd been through 4 surgeries with this little cyst on her ankle, and it wasn't infected. We had MRI and we had CT scan, we had labs. There was no real infection in there. And so she said, well, you just go in and I said, well, I don't know what I'm going to do. I mean, I'm not going to do anything more. She'd been to plastics up at the university. And so I said, sure, we'll go in and look. So I went in and looked, and I kind of cut out this cyst on her ankle, and I was digging around. I was almost ready to just close it up. And I saw this kind of black speck at the bottom of the wound. And I didn't know what it was. I thought it was maybe, I don't know what it was. And so I reached down and I pulled it, and out comes a twig, like a tree branch. I'm not kidding. It was almost the size of a pencil. It was all soft and squishy because it had been in her foot for like 6 months, but it had somehow wedged itself between bones in her foot and not visible on MRI. And I didn't see it on MRI either. Nobody else did, but I didn't see it either. So I pull this thing out, and like my nurse gasped. She didn't know what it was. And the anesthesiologist reaches over the curtain and he's like, what is that? What is that? And so we got on the back table, and it was a tree branch. And so that was a problem all along. So I sewed her up, and, I saved it for her and gave it to her. And I said, this doesn't really have anything to do with diabetes, but what happened here? And she said, a couple months ago, I was hiking, and now I remember, maybe this is when this started, but I kind of kicked a sagebrush and I didn't think anything of it. My foot got kind of scratched, but that's all I remember. And she's like, I kept hiking and it didn't really hurt. And I guess soon after this, so she had jammed a big piece of sagebrush branch into her foot, happened to weave its way in between the bones of her foot, and was just sitting in there. It was crazy story.
Wow. Oh, thank you for that. That's awesome. I'm so glad we got to hear that. Thank you.
I want to talk real briefly about, because you had asked me earlier about some of the more complex or advanced diabetic foot ulcer treatments. I just want to talk real briefly about that. There are some really cool things happening in the world of diabetic foot care. Very advanced things, and researchers and companies are putting a lot of money and resources towards this, because most diabetics, I believe still the number one reason for admission for a diabetic is their foot most commonly. And so it's a big problem across the country. And we already talked about the numbers. I mean, tens of millions of people get affected by this. And so if we can get diabetic foot wounds to heal, all the better. And so there are some very advanced things. I mean, the old time used to be, there's all kinds of old time treatments, but we've now gotten pretty advanced. There's biologic treatments. There's actually like almost living Band-Aids that you can put over a wound that has growth factors and all sorts of pretty advanced. There's biologic agents, literally living tissue, living cell that's basically woven into a Band-Aid that you can put over a wound. Wound care centers really are the forefront of handling this. I do some of it in my office, but if I have a wound that I think is really hard and past my level of expertise, I'll send it to a wound care center, and they're really good at it. And that's, they can spend all their time on that kind of a thing. But there are some really advanced and exciting treatments coming out over the last few years and certainly in the future.
One of the things that I don't see a lot of, Jason, is the diabetic toenails. Thankfully, my kids don't have those. But what are some of the things you do for a person that has those diabetic toenails and some of those common problems?
Every diabetic should have a foot doctor, have a card and have a foot doctor really on speed dial. It's really because diabetics can have serious problems crop up in a matter of a day or two. And so because of that, Medicare and insurance companies have decided to pay and cover for a patient to go to a doctor and have their nails trimmed. And so they can go every 61 days. And so in my office, it's every 9 weeks. If you're a diabetic and you have neuropathy, you can come into my office and I do a full foot exam. And including that, I can trim your toenails or I can trim down any calluses and look for any trouble spots. And we can do that every 61 days. And so every diabetic really should probably take advantage of that because you don't really need a doctor to trim your toenails. You've been doing it your whole life. But what it does do is gets those patients in front of a podiatrist fairly often. And so that's a really good thing. So we debride them and we have stuff in our office to take care of that because patients really can't do it on their own. What's sad is that you really have to be a diabetic in order to get that covered. And so there are patients, who are older or have back problems, or maybe they're on anticoagulants and they don't feel like they don't want to cut or they can't reach, or even they're blind. I mean, there's a lot of sad situations that they can't handle their own toenails, but if they're not diabetic, it's not covered. And so we have to try to find somewhere else for those people to go. But we do see our diabetics on a regular basis. But I think it's really, the patients see it as a way to get their toenails trimmed all the time, and their calluses trimmed up. But really the underlying principle behind that is that it gets the patients in front of a doctor quite often, and we can hopefully prevent anything serious from happening. And if there is a small wound or something, we get on it immediately. And so we get it before it becomes a big deal.
So the overarching message is really that frequency. They're in front of you is probably the most important thing.
And it's not just me, it's you guys too. I mean, you guys also do foot exams and typically my experience has been, in a primary care setting, if you guys see something you don't like, then you'll immediately send it over. And so all of those touches are good, a patient looking at their own feet, you guys looking at their feet, me looking at their feet, all of those things are only good. Patients ask me all the time if they can, get like a foot bath, and a lot of these products for your feet will say on the box, if you're a diabetic, don't use it. And I'm sure that there's some legal reason for that, but I tell patients to get it all the time. I mean, I want patients to spend time working on their feet. I want like every 10 minutes, if you're going to soak your feet every night for 10 minutes, that's all the better, because if there was a problem there, I'm sure you'd see it. That's what I like.
Should we have them go to those fish eating places where they kind of...
My wife did that in Mexico. Yeah. They have that here.
They have one of those in Layton Hills Mall. I think.
I was going to say that. They have it in Layton Hills Mall. Yeah.
So you should have one in your practice in the waiting room.
I know I should.
And the fish and the leeches, get them there.
The leeches, absolutely. I've seen a few wounds. When I was a resident, I was at the VA and I took off a big bandage and there were maggots in the wound.
Oh, man.
Yeah, it's kind of gross. It's actually a treatment, though. I mean, some doctors will prescribe medical maggots for some wounds to debride and kind of get rid of the dead tissue. But it's a little unnerving when you see that.
Oh, the joys of residency. So.
I know. Yep.
So speaking of wounds, let's take it to diabetic foot ulcers. What are the usual causes? I know that you had mentioned earlier that diabetes is not the cause, which I think many of us know. But what are the typical causes that you see?
Legos and sage bushes.
Yeah, sagebrushes and rattlesnakes. So
Yeah.
patients will say Legos, or they will say that I just stepped on something, and they'll also say that this just started yesterday, and it clearly didn't. And so most of the time, it's not a super exciting story. Most of the time, the cause is a wear spot on their foot. So your foot structure changes as you get older. Everybody's foot structure changes. You also lose some of the fat pad on the bottom of your foot. And so, you get to be 60 or 70 years of age, you're basically, just skin and bone down there. There's no real padding. The fat pad is kind of eroded away or migrated. And so there's not a lot of padding underneath the bones and ball of your foot. And so patients will walk on that without much padding, and they'll get a big callus there. Initially, they get a callus. That callus, if they keep walking, if they don't get that callus shaved down or treated, then that callus will become an ulcer. It will wear a hole in the skin. It's just that simple. It's like wearing a hole in your work gloves, shoveling, digging a hole all day in your yard. You might get a hole in your work gloves. The same thing happens to the skin on your foot. And so it's a wear spot. And that's a real challenge, because that is clearly a place that gets a lot of pressure when that patient is walking, because it was enough pressure to wear a hole right in the skin. And so, and it's usually on the bottom. And so the patient can't easily see it. And so for these reasons, it can get to be a little bit of a problem. Oftentimes, the first time the patient even knows that it's there is because their foot blows up like a balloon, because it's all swollen and they're infected and they're got a fever, and then we're off to the races and we're meeting them in the midnight in the ER kind of a thing. And so it's usually not a super exotic story about stepping on a Lego or rattlesnake. It's usually they wear a hole in the bottom of their foot simply because they cannot feel it. A non-diabetic, or you or I, would feel that if you're getting a wear spot that was wearing that hard in one spot, you'd feel it, you'd stop, you'd look. And diabetics get numb down there and they can't feel it. And so that's what happens.
That's a really good reminder. Thanks. I actually saw this kind of infographic. It was kind of like a visualized number line for the amount of pain you're in. And, you had like smiley faces for 0 and 1, and then it goes all the way up. And the description for number 10 was stepping on a Lego.
That's funny. I should add real quick. And that's why, Medicare and insurance companies will pay for diabetics to have a pair of shoes. They'll pay for shoes every year for people with diabetes, because there has been research that shows, look, if we can give a good pair of shoes to a patient who has diabetes, that may be the reason they don't get a foot ulcer that year. And a foot ulcer, I think the cost to the system is a lot of money. It's over $10,000. And so if that can be prevented by paying for, a pair of shoes for a couple $100, that's certainly worth it. And prevention is worth it. And they're actually, I don't have really anything to do with shoes. It's the primary care doctor has to be the one to fill out the paperwork. It's not from me. They have to have a diabetes doctor and being seeing them regularly to be eligible to get shoes. So they don't really care what the podiatrist thinks about that equation. But that is something that patients should take advantage of, is to get a good pair of diabetic shoes that has plenty of room and it's not going to cause rubbing spots. So at least you're not causing a problem from the shoes themselves.
How did these usual causes in America or in Utah and Ogden, how did those causes compare to the region or the country or the world? Are those different, or are they the same?
No, they're the same root causes. We find a lot of the more serious complications to be in lower socioeconomic areas. I mean, it kind of mirrors the local populations. If you have a local population that's really high in diabetes or lower socioeconomic and high obesity rates, that tends to be an area that's going to have high complications. Ogden has really good healthcare though, and has, for years, as I mentioned, the first clinic I worked for at McKay was Jack Wallen's clinic, he's retired now and doing research, but he's literally a world-renowned endocrinologist who is running a really big diabetes education program and clinic in Ogden that really benefited a lot of people. And so the care, I think, in the Ogden area is really, really good. There's doctors available to see patients. And so we do have good care there. When you get to areas that don't have as many doctors or have a higher concentration of diabetics or, lower socioeconomic status, don't have access to good healthcare, that's where you can see more and more problems that can end up in amputations. And, the problem with an amputation, obviously there's a ton of problems. That's That sounds a bit callous to say that, but an amputation is not only a tragic and sad happening, but it usually starts the hourglass on that patient's life. If a diabetic has to have their leg amputated, the studies show that about half of those patients don't live past about 5 years after that. And so that's why we really strive and work hard, and podiatrists take real pride in trying to prevent amputations and below knee amputations. The more we can prevent of those, the better quality of life we're giving to people, and the longer longevity of life we're giving to people.
Isn't it interesting, how that's such a telling milestone for someone's mortality? Is that, that experience they have with you is going to be the beginning of the hourglass for them.
I mean, the reason oftentimes an amputation happens because the patient does not have great vascular supply, right? So if they don't have great vascular supply to their leg, what does it look like to their heart or to their brain or their kidneys? I mean, it probably doesn't look great. And so, but that is definitely a sign and a signal that, things do not look good. And the one thing we can always do with our diabetic patients is all the diabetes stuff that we know of, is to drop your A1C and, diet and exercise and lose weight and be active and do things. And we think that a lot of the effects to your feet as well from diabetes can be stalled or even reversed a little bit, which is what we always work towards.
Well, you're at a vital crossroads where, they're coming as the most common presenting problem is their foot pain and their foot problems. And you're the one that ends up being, kind of that watchman at the crossroads for them, saying, this is a sign of what you need to do to get better. And so it's
right. No, it's interesting to say that, Jason, because that has happened. I'm sure it's happened dozens of times in my office, because I'll have patients come in, and sometimes a patient losing like their little pinky toe because of a diabetic foot infection that got, into the bone and got a bone infection, which, we haven't talked about this yet, but if it gets into the bone, we have to usually remove that bone. Doesn't matter how many antibiotics we give them and how long we give it for them. But if it gets into the bone, they're going to probably lose that bone. And so, sometimes, as you said, that's maybe the best thing that could happen to some of these patients, to kind of a shot across the bow. And I've had a lot of patients go through that. It's an embarrassing and scary and kind of a tragic thing to have us have to remove a body part. And we do that. And I've had, dozens, probably countless patients, way more than dozens, say to me, look, I'm never letting this happen again. And I'll see them a year later and they've lost a bunch of weight and they're active, and they, some of them become basically non-diabetic diabetics through that experience. And so, I love those stories because it does happen.
That's got to be way satisfying. So
yeah, for sure.
I guess being that watchman, if you could tell the members of Ogden Surgical Medical Society kind of one thing, what would it be? What would be your recommendation for us?
If we're talking about diabetes specifically, we want to make sure that diabetics are looking at their feet and making sure that their feet are part of their priorities. And whenever you see a diabetic in your practice, look at their feet, talk about their feet. And even if you don't do a super detailed diabetic exam, because maybe you don't feel like you have the right materials or tools or all that really needs to be looked at is look at their feet, make sure there's no cuts, blisters. If something looks funny, let's just get attention to it. And actually reinforce that to your patients and just say, get someone to look at your feet every day. If you see any blood on the bathroom floor, call somebody. Have the phone number of someone that can look at that. There's plenty of podiatrists around in Ogden, and all the podiatrists are happy to see that and are well-trained to handle that stuff. And so it's really about getting eyes on people's feet and reminding diabetics that their feet really matter, and getting their attention to their feet once a day. And if they can't see down there, then get a mirror and put on their foot. If they put it on the ground so they can see the bottom of their foot, or get someone else to look at their foot. Really, that's the take-home message that I try to send to get out to everyone, is look at your feet every day. And if you see something you don't like, get in to see somebody.
Well, Jason, I will, I see them at a very young age with their type 1 diabetes. And from our discussion tonight, I will change my practice to just start to make sure every time I have one of them coming in, I will check their feet, even though their feet are kind of young and healthy still. I know that if it sets a tone and expectation going forward, I will repent and do a better job of examining the feet of my dad.
That's a good point. So, you're right. I mean, your patients, I don't see foot problems, but I definitely have in the 20s. I mean, unfortunately, I've had to amputate a few digits or part of a foot in a type 1 diabetic in their 20s. I mean, sad cases, but it does happen. So you're right. I mean, those habits could start when they're young and hopefully stay with them.
Well, I will commit to doing that better to help them get good habits and emphasize the importance that I'll elevate that exam as well. So thank you.
You bet.
Dr. Bruse, thank you so much for spending time with us and sharing with us in this discussion. It's been really, really great just for me to be part of this. So thank you on behalf of me, but thank you on behalf of all the members of the Ogden Surgical Medical Society. And we really do wish you the best, and we appreciate you being here.
You're welcome. Thanks, guys. Really appreciate it.
The producers of this show were Clark Madsen, MD and MS, Teresa Puskedra, MPC, and the Ogden Surgical Medical Society Board of Directors. The executive director is Teresa Puskedra. Your hosts for tonight was Jason Hoagland, MD, and Scott Moore, DO. Editing and sound design were by Colton Gomez, and this is all supported by the Ogden Surgical Medical Society, like you.